he has had a bypass operation 10 years ago with 2 grafts, one lima to the LAD and a T graft to the PDA and the marginal branch. He has symptoms of dyspnea and exertion, and he was hospitalized in our clinic several months ago with pulmonary edema. During his investigation, we see that he had patent both grafts. And from the echo, we demonstrated a calcified tricuspid aortic valve with a valve area of 0.7 square centimeters. You can appreciate the low ejection fraction. So he had a low flow, low gradient aortic stenosis. This patient is a Greek patient who lives 9 months in Germany and 3 months in Greece. So we advised him to seek for treatment in Germany. The patient has declined from 3 centers percutaneous treatment because, as you can see with the CT scan, he had an extreme large annulus of 860 square millimeters, a perimeter of 105 millimeters, and a mean diameter of 33 millimeters. So we know that both valve prosthesis, balloon and expandable valve, have a cutoff point of 6.83 square millimeters for the balloon expandable and a perimeter of 94.2 millimeters for the self-expanded valves. And this patient immediately became an off-label patient for treatment. As you can see, this is a rare entity because in a large single-center European center experience, you can see that only 6 patients, 0.27%, had a valve perimeter, a valve area above 840 millimeters. So we decided to proceed with the patient because he came back in Greece and he asked if we could treat his valve. We explained thoroughly the risks of treatment of this large annulus valve, and we decided to proceed with the XL My valve 32 millimeters with additional 6 mL to achieve an expansion of 33.5 millimeters. The main access was the right femoral artery because we could use the 2 proglides. You can see the puncture site was done very nice, the aortogram. And we had a total uneventful course, a total uneventful procedure, a pre-dilatation. Very easily the valve crossed with a Novi wire. And you can see that this huge valve took us several seconds to inflate and also to deflate. I have to say that this is the largest valve that we have placed in our team. And you see still inflating and now becomes the deflation. The result was acceptable with minor PVL. The right groin was okay. And that was, this is the echo before discharge with low gradient and a good LV function. The patient was hospitalized for 4 days, but he came back in day 7 with dizziness. He had a complete AV block and we placed a permanent pacemaker. Thank you very much for your attention.
Very, very good case. I think this is exactly what we would like to see here, and pushing the envelope exactly, and doing TAVIs in borderline cases. And I think that is the reason why TAVI is here to stay and is going to progress, because it gives you the opportunity to even go further and further and do things on borderline cases. Maybe Dr. Sparias has a comment on that, because I see you want to say something.
Just a funny comment. Germans cannot do it, but Greeks can do it. Congratulations.
No, Kostas, can you hear me?
Yes, I know.
I think that the particular valve was not probably available at that time. I don't know, because I thoroughly asked the patient and he said that we went to 3 centers and with balloon expandable, but probably they didn't have the MyValve system. I don't have any other explanation.
A.G.H, congratulations, it's Leonidas. That's the reason we can prefer a certain platform And we have a workhorse platform in our lab, but then we should know and should be aware of alternatives to give the patients possibilities, because we have different subsets. And now, as the indication broadens, we should have different solutions to provide.
Congratulations, A.G.H. I noticed, do you always predilate in bicuspid valve? And at this case, what size balloon did you use for predilatation? I mean, did you downsize or?
No, the valve was tricuspid, not bicuspid.
Sorry.
We predilate with a 22 millimeter balloon. And as we wanted to advance a big valve, we wanted to be sure that we will cross the calcified original valve.
Just a comment to say that using the X-large my valve in aortic stenosis, it makes the procedure easier compared to using the extra-large my valve in aortic regurgitation. And so you had the benefit of having a little of calcium. It was not a very calcified valve, but at least it was stenosis and a little of calcium. So that was good, and we have similar experience with 2 or 3 cases of extra-larges that wouldn't be candidates for other valves. So this is exactly what Leonidas said. It demonstrates that you should have an open mind and use multiple platforms, not exclude platforms if you don't use them, because every patient at the end of the day may be good or best for one platform and not the others.
Exactly. And having that said, don't fear. If you have calcification, then you have something to grab on. And even in those borderline cases, I think it does worth the effort, as you did very well, to take the chance and go ahead and do it. So our next case